Next, we have Smruti Mahapatra. She is a medical student at Tulane, and she's been doing some really incredible research work with our neurosurgery group, and she'll be talking to you all about using brachytherapy for oligometastases.
Hi everyone, I am Smruti. I'm a third year medical student at Tulane University. Today I'll be talking about this very exciting clinical trial done by my mentors, Dr. Marcus Ware and Dr. Clayton Smith here in the audience at Ochsner Medical Center. This study investigated the use of brachytherapy in combination with minimally invasive keyhole craniotomy for the treatment of newly diagnosed brain oligometastases. So, I think most of us are aware that brain metastases are the most common form of intracranial tumors. I just want to stop. And while conventional treatments like whole brain radiotherapy and stereotactic radiosurgery are useful, they have their limitations, especially when dealing with larger tumors or irregular resection cavity sizes. So, brachytherapy was one such option. It involves the placement of radioactive isotopes into the tumor or the resection cavity. Traditionally, it was done with iodine 125 seeds, but recently we prefer cesium 131 seeds because of its faster therapeutic dose delivery, shorter half life compared to iodine, and more predictable treatment course. Another option is minimally invasive keyhole craniotomy, which, as the name suggests, involves creating a small targeted incision with the help of neuronavigation for real time guidance. The aim is to achieve gross total resection. So, our study aimed to combine both these techniques to treat newly diagnosed brain oligometastases. This was a prospective single center study carried out at Ochsner Medical University from Medical Center, from 2019 to 2021. 21 patients were enrolled and followed post-op every 2 months until local recurrence, death, or the study endpoint at 2 years. The primary endpoint was freedom from local progression, while the secondary endpoints included quality of life and treatment efficacy. At each visit, a brain MRI was performed to monitor tumor progression, and functional outcomes were measured using the KPS, ECOG, and the mini mental status exams. The surgical workflow involved tumor resection via minimally invasive craniotomy, followed by the cesium seed implantation in the resection cavity, after which post-op imaging and dosimetric computations were performed. To plan seed placement, we used pre-op T1 weighted MRIs. The planned radiation dose was 80 grays to a 5 millimeter depth. Following maximal safe tumor resection, cesium seeds were placed in the resection cavity and immobilized using ethicon. This was done by the neurosurgeon in consensus with the radiation oncologist present in the room. Moving on to the results, we had 9 male and 12 female participants. The median age was 60. Gross total resection was achieved for all patients except one who had to undergo a partial resection. Most metastases originated from the lung and the breast. The most frequent location for intracranial lesions was the cerebellum and the frontal lobes. An average of 17 seeds were placed, delivering a total activity of about 55 millicuries. The dose received by 90% of the cavity was 89.8 grays, with 93.2% of the cavity receiving at least 100% of the planned dose. Coming to the changes in tumor volume, the median tumor volume decreased by 51.78% from baseline to post-op. Here's an image series showing a steady decrease in tumor volume at 2 weeks, 2 months, and 4 months post-op, although this difference was not statistically significant. Okay, moving on to survival. The median survival for the study was 177 days or 5.8 months. 5 participants were alive at the time of this report. And if 5.8 months seems a little on the lower side to you, you'd be right, because most studies reported a survival of about 9 to 15 months using brachytherapy. That being said, the study was done from 2019 to 2021, which coincided with the COVID 19 pandemic. COVID 19 was the reason for 5 out of 16 deaths among our study subjects. However, none of these deaths were due to local or distant tumor recurrences. Okay, moving on to the good news. Our primary endpoint was freedom from local progression, which was 91.67%. Only one participant developed a local recurrence. This was the same participant who had to undergo a partial resection of the tumor, and the median time to recurrence was 146 days. All the 5 patients who are alive today remain recurrence free. We did see 4 instances of distant progression, bringing our 1 year distant freedom from progression rate to 53.91%, and this occurred at a median time from post op at 143 days. Another big highlight of this study was that there were no instances of radiation necrosis reported. There was one reported case of a pseudomeningeocele, which was radiographic and didn't need surgery. But apart from that, there were no other adverse effects reported. We also looked at functional outcomes and quality of life metrics. Post treatment, patients reported improvements in symptoms like reduction in seizure frequency, improvements in mobility and coordination. However, the outcomes regarding social and emotional variables were mixed, and this was likely multifactorial due to the primary disease progression itself, as well as the concurrent COVID 19 pandemic. Now, looking at the survival data, one obvious question is why would some patients survive until the end of the study or more than 2 years while the others didn't? The COVID 19 pandemic aside, was there something else influencing long term survival among these patients? So, this was the second half of the study. We took patients and divided them into 2 groups. The first one was the long term survivors, referred to as LTS here, which included 6 patients who survived more than 2 years. The other group was short term survivors or STS, and this included 15 patients who lived less than 2 years. When compared uh, in survival durations, the median survival in short term survivor patients was only 2.2 months. So, next, we investigated if there was a difference in the age or sex in these 2 groups. Long term survivor patients did tend to be younger than short term survivor patients, and the difference did tend towards statistical significance. However, this is a small sample set, so it didn't really achieve significance. However, sex differences were significant and striking. Female patients were 13.75 times more likely to be long term survivals compared to males. Next, we looked at tumor characteristics. The only variables that approached statistical significance are shown here. LTS patients had smaller tumor and resection cavity volumes and higher V200 coverage. No other clinical parameter, including interval between diagnosis and surgery, operative time, number of seeds, radiation dose, blood loss, post op hospital stay, local or distant recurrence, was significant. Next, we checked the entire spectrum of socioeconomic factors, including race, marital status, employment, income, social support, alcohol, and smoking use. We also looked at psychiatric comorbidities. 2 out of 6 LTS patients had documented psychiatric conditions compared to 9 out of 15 patients in the STS group. The most prevalent conditions included major depressive disorder, generalized anxiety disorder, insomnia, and substance use. However, none of the socioeconomic variables showed any significant differences between the two groups. So, what actually made a difference? It was functional status between the two groups. When compared, when the overall KPS and ECOG scores were compared, there was a highly significant difference. LTS patients had higher KPS and lower ECOG scores overall across all time points. Now, this trend continued even when we looked at individual time points, although the difference between the two groups was not always statistically significant. We also compared the extent of disease among the two groups. We used two RAD-ONC defined prognostic tools, namely the RPA class and the DSGPA score. These factors use age, primary tumor characteristics, number of brain mets, presence of extracranial mets, and the KPS status to estimate survival. However, there was no statistical difference between the RPA class or the DSGPA index between the two groups. Finally, we looked at quality of life metrics. Long-term survivors reported better sleep, more energy, and most importantly, they were able to restart driving. They also reported significantly lower levels of anxiety and worry about their condition worsening. They also reported higher acceptance of their illness. Coming to social emotional variables, long-term survivor patients were able to enjoy life better, felt more close to friends, and were more content with their quality of life. However, just based on these results, it is very difficult to say if this was the reason those patients survived longer or if this was a consequence of them surviving longer. Now, this study definitely had several limitations. The overall survival was low due to the COVID-19 pandemic. The sample size was small. It was a single institution study. There was no control arm, and the quality of life was affected by the pandemic too. Even with these limitations, this combined technique of minimally invasive keyhole craniotomy and brachytherapy showed promising efficacy in treating brain oligometastases with a high local tumor control and low toxicity. Our findings also suggest that functional and quality of life measures may be better predictors of long-term survival rather than conventional clinical parameters. We definitely need larger studies to better understand survival, quality of life, and dosimetric correlations. These are my references. The study was sponsored by ISORE Medical. That's my mentor, Dr. Marcus Ware. Thank you for your attention and happy to take questions later.
When I'm thinking about when to use steroids versus bevacizumab, there's a few things that I think about. One, am I using bevacizumab just for cerebral edema management, or am I also using it for tumor treatment? Because it's approved for both of those things, for the radiation necrosis and edema, as well as a second line for glioblastoma. And so if a patient develops symptoms that I think are related to edema, I'll often start with steroids and try to do a burst and a rapid taper. I don't like my patients to be on steroids long term because it has a lot of side effects that are not fun for the patient and not good for their health. And so the times when I switch to bevacizumab, when it's not for also treating the tumor, would be if a patient has persistent symptoms related to cerebral edema and the symptoms are steroid dependent. So they're recurrent when we're trying to come off of steroids. The other time I would use bevacizumab is, for second or third line glioblastoma treatment. If I have a patient who has a lot of symptoms from cerebral edema and their tumor is growing, then I may consider using bevacizumab. It is approved here, and so I haven't had trouble with that outside of insurance companies sometimes being particular about which exact biosimilar we use. Anyone else have questions? Okay, I'll ask a question then. So sorry to put you all on the spot with questions that I have. So, Dr. Smith, from your perspective, when we're thinking about radiation therapy for brain tumors, primary or metastatic brain tumors, you talked a lot about how radiation has changed over time, where it's gone from whole brain radiation to now where we can be kind of pretty focused. What do you see as kind of the next advancements in brain tumor treatment from a radiation standpoint?
Yep. So there's a couple of different things. One is proton therapy, which is protons instead of X-rays to deliver the radiation. The advantage there is with X-rays, there's some exit dose. So if this is the tumor, then you get some exit dose beyond the tumor. With proton therapy, it deposits the dose where you aim it, and there's really nothing beyond that. So it spares tissue. There's no difference in tumor control, but reduction in side effects. The issue has been that they usually cost $40 million plus, and so there aren't a lot of centers. There's probably 40 something, I think, now in the country, and so getting to a center with proton therapy can be difficult. That also hasn't been demonstrated yet, particularly for glioblastoma, to improve survival. So really it is just reducing side effects from that treatment. There are some pediatric things, or pediatric tumors, such as medulloblastoma, where we're treating the entire craniospinal axis. That's perfect for them. And actually, I also treat our pediatric patients. So those patients, I will actually, if they are able to travel, recommend that they go to a proton therapy center, just because it's much fewer side effects than what we would treat with X-rays. The other thing is, we haven't mentioned it today, but meningiomas, they're considered a benign tumor. There's something called Lutathera, which is lutetium-177, which is a radionuclide that's a liquid. And so it's injected, but it is taken up by a sort of dotatate receptors within meningiomas. So far, there's just been a phase 2 trial showing sort of refractory meningiomas that keep recurring. But because it targets the radiation to those tumors, it does slow down the growth, and that seems to be a promising area for meningiomas in particular. For glioblastoma, we still have ongoing trials looking at dose escalation, but nothing has panned out, and that's sort of, I kind of commiserate with my chemotherapy neuro-oncology colleagues, where we try all of these different medications and ways of delivering them in combinations, and it's just a very resistant type of tumor. But yeah, so I think Lutathera, and then proton therapy is coming down. I think as that technology gets cheaper to produce, then more places will get them. So.
Thank you. And then Dr. Brown, I'm not going to let you get away without answering something. So, from your perspective, how do you approach having a new patient with a brain tumor when you're going into surgery, and what sorts of things do you take into consideration for your kind of surgical approach, and how much you resect, and what sorts of tools help you with that?
Sure. So as neurosurgeons, we typically get the privilege and the challenge of being the first interaction with a lot of these patients, seeing in the ER with a new deficit. And so that's a challenge to kind of bring on the reality. A lot of times the likelihood of what this patient's up against, but how much do you lay on them early on and things. So I like to keep it general at first, one step at a time kind of thing. That, the first step with this is, with most things in the brain that are accessible, the first step is to get as much of it as we can out safely. And so I kind of talk to that, effect with the patient, and start to look at how we're going to do that. And with surgery, kind of along what Clayton was talking about, I mean, the things that have improved with surgery is how to be more precise with removing the bad and keeping the good. It doesn't help these patients to remove a super maximal resection and cause them a deficit. So the adjuncts we have for that are mainly navigation, so preoperative MRIs, stealth imaging on CT to guide us to the specific target. We have intra-op things like ultrasound to guide normal versus abnormal tissue. We have fluorescence, which we can give to the patient orally, preoperatively, that will allow us to place a filter on our microscope that highlights abnormal tissue from normal tissue intraoperatively to help us maximize the extent of our resection. The key, though, is to not cause harm. So when things are in very eloquent locations, we can use intraoperative electrical monitoring, and so we can actually stimulate for where the primary motor cortex is and make our cortisotomy obviously away from that area. Our retractors over time have advanced to where, historically it was kind of like these bendable retractors that we just sort of suction a pathway through the brain and kind of expand the brain. Now we have retractors that have a navigated stylet that we can pre-plan a trajectory from the surface to our tumor that avoids. We can do preoperative imaging to see where sort of the primary language tracks or the primary motor tracks are, and then guide our navigated probe adjacent to those. And these retractors are designed to sort of split the brain fibers as opposed to destroying them on the way, so that we can create a corridor that's safe. And then we remove the inner stylet and we have just sort of a fixed conduit that we can work through to get to the affected tissue. So, those are the adjuncts to try to be more precise, but to still preserve function. This disease, especially GBM, is going to be cured by the other folks on this panel. I feel like it's not going to be cured by surgery, but there will always be, I think, a role for surgery. We can make a profound effect. Someone comes in aphasic with a lot of edema, and if we can remove that enhancing part, in 2 weeks that edema is often markedly improved, and that person has a good quality of life going forward. And so that's the main thing I prioritize when I'm looking at these patients, because surgical, it is true that maximal resection is best for the patient's longevity, but if that's at the risk of quality of life, then it doesn't make a lot of sense, because in general we're making a 4 to 6 month difference in this disease with a great resection versus a biopsy at the extremes. But if that 4 to 6 months is with an aphasia or something like that, then it's perhaps not worth it. But hopefully in the future, advances that Dr. Golden were speaking of, we'll be able to get to the molecular level of these tumors and eradicate them, without the need of surgery. So.
All right, thank you so much. Yes, go ahead.
So you mentioned the MGMT methylation status and how that results, if it's unmethylated, hypermethylated, then the patients are going to be more resistant to chemotherapy, radiotherapy. I'm curious how and when you talk to your patients about that, and then whether that changes, whether you might recommend trials for them or not, especially if they're younger and fitter.
Yeah, that's a great question. I generally talk about it as soon as the patient wants to. So, when you have a patient who has just gotten this diagnosis of a terminal brain tumor where their likely overall survival is less than 2 years, you have two main camps of patients. There's the one camp of patient who just heard this and they said, I can't tolerate any more information today. Let's let you process this and come back later. To the other camp at the extreme saying, okay, great, now what do I do? Then what's next? I want all the information. And so for MGMT methylation status specifically, that's often something that people who aren't healthcare providers just don't know about. And so that often comes up for me if I'm talking with patients about survival. What do things look like for you if you do treatment versus if you don't? What are your different treatment options? Then we can say, because of your molecular profile, specifically with your MGMT methylation status, this is what I would expect on average for a patient like you. Yeah, absolutely. So, like we talked about, these patients really do need multidisciplinary care with neurosurgeons and radiation oncologists and neuro-oncologists, as well as other support systems. Things like nutrition and social work often become really important for these patients. What we do is we have a weekly tumor board where we meet with our neuroradiologist and our neuropathologist. For our new patients, we'll go over their initial imaging, their presentation, their postoperative imaging, their pathology, and all talk together about what are the best next steps for this patient. Generally, those next steps are implemented in our multidisciplinary clinic, which is later that day, where we have a patient come in who sees their surgeon for their postoperative appointment. This is generally 2 weeks or so after their surgery. And then they also see me and Dr. Smith for a discussion of the next steps and treatment options. Yeah, we have it once a week currently. Any other questions? All right, well, thank you all so much for coming and listening to our neuro-oncology, and thanks to all of our speakers and panel participants. I really appreciate all of you, and have a great day.